All right, everyone. Once again, I welcome you to all to today's session. My name is Keegan, and I will be hosting this session on behalf of the Public Health Alliance for Genomic Epidemiology and be moderating today's webinar. The format of today's session will be that Dr. Masab will be presenting for about 40 minutes, after which we will be having a Q&A session for about 10 minutes. I please ask that all listeners feel free to post your questions in the Q&A session during the chat. All right. I will now be introducing Dr. Masab. All right. He is a virologist and genomic epidemiologist, currently serving as the principal officer and head of the Department of Virology at the National Institute of Health in Pakistan. He leads national programs in molecular diagnostics, genomic surveillance, and outbreak response for priority infectious diseases. A pioneer of genomic surveillance in Pakistan, Dr. Umair established the country's first public health next-generation sequencing facility and played a key role in the national COVID-19 diagnostic response. His work bridges science and policy, where he has translated complex genomic data into actionable insights for decision makers through regular technical briefings during public health emergencies. He is a member of the World Health Organization Technical Working Group on Mpox genomic surveillance and a recipient of the Emerging Leader in International Infectious Diseases Award by the International Society for Infectious Diseases. He has authored over 80 peer-reviewed publications and contributed more than 4,500 genome sequences to global databases. He is also the author of the book Frontlines of the Pandemic, a virologist's journey from crisis to genomic revolution, reflecting his experience at the interface of laboratory science, genomic innovation, and policy response. His current work focuses on advancing the use of genomic data for public health decision-making and strengthening science to policy communication. Thank you very much, Dr. Masab. Over to you.
Bismillahirrahmanirrahim. Thank you so much, Keegan, for the introduction. Good morning, good afternoon, everyone. I'm grateful to PHA4GE for the invitation. It's a pleasure to be joining you all, especially colleagues from the global public health genomic community. So today I will be talking and basically discussing a very important topic in pathogen genomics, which is, I think, very much underemphasized, and it is how we can communicate genomic data for public health action. We have seen that over the past few years, a lot of genomic sequencing capacities, they have been developed in many countries, including the LMICs. However, just doing sequencing is not enough. And the true value of genomic surveillance comes whenever, whenever we can convert this or translate this genomic data into timely, understandable, and actionable information. So today I will share some of my examples from COVID pandemic, from the Mpox emergency, and from some other outbreaks where we used genomic data to inform public health decision-making and how we communicated this data to different stakeholders. So this slide basically it summarizes the central message of my talk. So as it states that a sequence alone, it does not save lives. So unless the genomic data is translated into an actionable intelligence, it remains of limited value. And basically the process, it starts by collecting clinical or environmental samples, either during routine surveillance or in outbreak investigations. And then from these samples, sequencing is done, and then bioinformatic analysis, and then genomic interpretation. So, but important here is that genomic interpretation, it's not the endpoint. And the critical next step is this communication of this genomic data to stakeholders. And because with this translation and then communication to the stakeholders, different public health actions can be taken. So it can include either enhancing surveillance, maybe targeting vaccines, targeted vaccinations, or maybe preparing hospitals or risk communications. So here the key message is that public health impact occurs only when genomic data is translated into actionable information and communicated effectively for the right stakeholders. So one of the key gaps that I see at the global level in pathogen genomic is that transforming this data into actionable intelligence. So, converting the raw genomic data that we generate in the lab to an actionable form. And, laboratories, they generate a lot of technical information, like they make phylogenetic trees through this genomic data. They do mutation analysis, cluster analysis, and so on. But this technical information is not always used for a decision. And most of the time, the decision, it comes from how this technical information is interpreted into risk. So for example, when there is a new mutation detected, the risk, if the risk is a possible immune escape, then based on that interpretation, a public health action is taken. Similarly, for increased clustering, the risk may be active transmission. And similarly, for new lineage introduction, the risk would be broader associated importation. So here again, the key message is that public health decisions are not made from sequences. They are made from the risk that we interpret from those sequences. So another important thing to understand is that who actually use pathogen genomic data. So it's important to understand that pathogen genomic data is being used by multiple stakeholders. So sometimes we think that this is a single area, but it's not the case. It's a larger ecosystem where multiple stakeholders are involved. So for example, policymakers, they use genomic data to basically guide preparedness measures, or maybe to allocate resources, maybe to devise strategic vaccination policies, or maybe border policies. So they use data for that purpose. On the other hand, clinicians, they use genomic data to basically get information regarding patient treatment, whether there are co-infections or not, so and how severe disease can be. On the other hand, epidemiologists, they use this genomic data to basically investigate the transmission dynamics of a pathogen. So how the pathogen is evolving and how it is spreading in a particular setting. Similarly, IPC teams, they also use genomic data for basically hospital preparedness and for containing such outbreaks in hospital settings. Diagnostic labs, they can use genomic data to evaluate the effectiveness of the diagnostic assays. So, by looking at some mutations that may affect primer binding or something like that, so they can evaluate the diagnostic assays based on this genomic data. Then there are vaccine programs that also use this genomic data either to see which variant is circulating, either there is a lineage replacement, and for strain selection vaccine. So they use this genomic data. Media also uses genomic data, and the purpose is to basically communicate risk and to raise awareness among population. And similarly, there are international agencies like WHO and CDC. They also use pathogen genomic data to basically do, you can say, a global risk assessment, a coordinated global risk assessment. So important point here to understand, and that what I want to say is that genomics 7 is a collaborative ecosystem, and its value is realized only through multi-sectoral integration. Another important point to understand is that different stakeholders, they need different message. So communicating same genomic information to different stakeholders in the same way may not be effective. So we have to communicate the same genomic information in a different form to different stakeholders, because not all the stakeholders, they have the exact amount of knowledge about the genomics, pathogen genomics or such data, and they require a different level of, and they have different level of technical expertise as well. So we need to, frame our message according to the stakeholder. So for instance, for policymakers, the genomic information should be simple, it should be concise, and it should be actionable, because they are more concerned about what risk it has, what is the urgency, and what are the recommendations. For clinicians, the information, the message that we are communicating, it should have clinical interpretation, because the clinicians, they are more concerned about the severity, about diagnosis, and about treatment implications. And as I mentioned, for epidemiologists, this is one group I think which requires the most technical and analytical genomic data, because they are investigating how a pathogen is transmitting, or how it is spreading in a community. Then for IPC teams, the genomic data, it should be communicated in a form of an operational guidance, so that they can take specific actions regarding risk assessment. For vaccine programs, again, they also require a lot of technical information, but mostly it is in form of evidence summaries. So what they need is, they need what strain is circulating, how it is evolving, and are there any escape mutants or not. And for media or for public, the genomic message, it's completely different. So it should be basically clear, it should be balanced, and there should not be any alarm or panic. And the main purpose for this is that media, they can use this genomic information to basically raise awareness about a particular pathogen, or they can communicate risks. So here again, the concept here is that communicating same genomic information to all the different stakeholders is not a good idea. So it's not the case where one size fits for all. So we have to modify our message whenever we are communicating genomic data according to our audience. So another global challenge that I see when we talk about pathogen genomics is that there is no genomic to action framework. And what I mean by that is that, yes, we do generate genomic data, but there are no predefined actions that can be taken, or there is no predefined action framework that can tell what action to take when we report a genomic signal. So for example, when there is a new VOC detected and it has an increased transmission risk, so one of the predefined action would be to enhance or to increase the surveillance. Similarly, in case of, let's say, a mutation affecting diagnostics that can have a potential false negative, so a predefined action would be a diagnostic review in this case. So I think this framework at the moment, I don't see it's available at the global level, which can tell what action to take if there is a particular situation, if there is a particular genomic signal, what predefined action should we take. So whenever we are mostly communicating data, genomic data, it's more descriptive rather than operational. And by having such a genomic to action framework, we can always give a more structured and a more calibrated response or an action. And I think such a framework is very important, especially for low middle income countries where there are limited resources. So genomic intelligence should be translated into predefined evidence-based responses. So there are a number of challenges when we talk about communicating genomic data. And one of the major challenges is the complexity of genomic data. So we all know that genomic data is inherently complex. So there are mutations, there are phylogenetic trees, lineage classifications, all of these complexity, they add challenges for in terms of communicating to different stakeholders, especially people who are non-technical. Second, challenge that I see is that pathogens, they evolve very rapidly. So especially the viruses, and one variant present at a particular time period may not be prevalent or may not be dominant in a very short period of time. So we need to change our recommendation based on how the pathogen is evolving. So this is another challenge that we see when we communicate genomic data to different stakeholders. Another important challenge is that we have to communicate the genomic data to multiple stakeholders. So it's not one single stakeholder. And as I mentioned previously, different stakeholders have different understanding of the genomic data. So policymakers, they have little, most of the policymakers, they are non-technical, they have limited background of the genomics. So communicating a genomic data to a policymaker will be different as compared to communicating it to an epidemiologist or to a lab person. So that is another challenge when we talk about communicating genomic data effectively. Uh, Variable data quality, it's again another challenge. So we see that a low genome coverage can be a challenge, especially when we are looking at important mutations, and if there are low coverage or dropouts in that area, then that can cause uh, problem when we are talking about what action should be taking or how we translate it. So contamination, incomplete metadata, and sample bias, all these contribute to some of the challenges. Then there is limited genomic literacy, as I mentioned. Not all stakeholders have, relative information or knowledge about genomics, and whenever we use scientific or technical jargons, so they may not be understandable by all the audiences. And lastly, balancing urgency is also a challenge. So a lot of the times we know that we don't have complete scientific information, but we have to, especially the public health authorities, they have to take action. So that sometimes how we communicate uncertainty, that is also a challenge when we talk about communicating this genomic data. Okay, so now I will share some of my examples of how I have been, communicating pathogen genomic data to different stakeholders. So this is a snapshot from the SARS-CoV-2 pandemic times. So here I'm, presenting SARS-CoV-2 genomics data to our National Command and Operation Center. So this basically forum had, multiple stakeholders. Some of them were highly technical and some of them were non-technical. So this NCOC, it was basically led by our Minister of Planning and Development, who was obviously a non-technical person, and this was co-chaired by a serving military general, who was also again non-technical about genomics. But on the other hand, we also had members like our health minister, who was an infectious disease expert, a globally renowned expert, and then we had epidemiologist, and then CEO NIH. So you can see that in this scenario, I had audience which included both technical and non-technical experts. So for me here, the challenge was how I can communicate the genomic data effectively to all these diverse people. And initially, honestly speaking, I used to present a lot of the technical information, like presenting phylogenetic trees, talking too much about the mutations. And I remember then there was a time that the chairman interrupted me during the talk and said, "Can you please simplify the message for us?" So that time I realized that I have to modify my message or frame it so that it can be understandable for all the members of NCOC. So because these policymakers, they are more interested in finding out uh, practical, they have practical questions and they want concise answers. So they are more interested in knowing like what variant is circulating, what impact it has for us, how it is evolving, and like what actions do we need to take, rather than going into the technical details of a pathogen's genome. So just keep that in mind. So presenting genomic data to policymakers can be challenging, and just I wanted to basically share here that whenever you communicate genomic data, make sure that you understand to whom you are communicating the genomic data. So you have the awareness of your audience. This is very key. So here I'll share one of the real-time examples how we used SARS-CoV-2 genomic surveillance data to inform public health action at the national level. So in early 2021, on the right side you can see the epi curve. It's the basically national case-based data of SARS-CoV-2, and you will see that in January, February, the second wave in Pakistan was on the decline. However, on the left side, which shows our lab and basically the genomic data, you can see that the alpha variant, which was the first variant of concern, it was increasing, especially in February. There was an exponential increase. So we communicated this data in a very timely manner to NCOC, and we basically proposed that there may be a new surge of cases, or there may be a new third wave, and this is exactly what happened. In April 2021, the third wave of COVID-19 in Pakistan started, and it was basically predominated by alpha variant. So what it did, by providing timely information to our health authorities, I think it gave them time. It gave them time to take action, or basically to prepare. It gave time for hospitals to prepare for a possible surge, and it gave them, time to strengthen the surveillance and to increase the diagnostic capacities in Pakistan at that time. So here again, the signal here was and when I say signal, it's basically due to the genomics that we were doing. So the signal here was the rapid increase of alpha variant in Pakistan, and the interpretation was a incoming transmission wave. And the major public health actions that were taken at that time was basically preparing for a possible and surge, so preparing our hospital facilities and increasing surveillance at that time. So we have been using same you can say method or genomic surveillance of SARS-CoV-2 to inform public health action at the national level, not only during the third wave, but before the fourth wave, before the fifth wave, sixth waves, and onwards. So we again reported the introduction and then the spread of Delta variant before the fourth wave to our NCOC and our health authorities. And similarly, before the fifth wave, we reported the introduction of Omicron, and then its rapid spread to different geographic regions of Pakistan. And similarly, in the subsequent waves, we reported different subvariants of Omicron. So again, here this message was very communicated in a timely manner to the right stakeholders and at the right time. And what it basically it led to very timely public health actions, either increasing the surveillance, increasing diagnostic capacities, or increasing or basically increasing surveillance at the point of entries, or implementing some travel restrictions. So all these measures, they were supported based on the genomic data or genomic findings that we were sharing with our NCOC. So another example, I really wanted to share this with all of you, is that is of the Mpox emergency. So we all know Mpox caused an outbreak in 2022-23, and it was declared as a public health emergency of international concern. So I had to communicate genomic data of Mpox to our National Command and Operation Center. But this time, the members of the NCOC were different as compared to the SARS-CoV-2 pandemic. So here, the members were mostly technical experts. So we had, representation from our epidemiology section, from surveillance section, from lab section. NIH was part of this NCOC platform. So here I had to, again, keep in mind that here the audience was highly technical. So my message should also be technical whenever I communicate such findings to such audience. So I deliberately changed my message and I made it more technical, so that it's again, but it should be in a way that it's understandable for all the audience. So Based on that, different public health measures were taken. And this is one of the first examples. So we we started doing genomic surveillance of mpox in 2022, and during 2022-23 we started screening travelers returning from especially those countries that were reporting mpox, or those that were already endemic for mpox. So we started doing testing for them at NIH. And in April 2023, we basically uh, reported the first case of mpox in Pakistan. And this was again a patient returning from a Gulf country. And we used metagenome sequencing here to identify, the clade of the virus. And we did this, sequencing within a very short period of time. So here, what was the finding based on our metagenome sequencing? So we identified the clade 2B, and most importantly, the lineage was a very rare lineage, A.2.1. So and since we used the metagenomic approach, so we also retrieved the VZV virus infection. So this was a co-infected case. And we reported these findings to our health authorities, to NCOC, to our airport administration as well. So what was the signal here, and what was the interpretation, and what action was taken? So as I mentioned, signal here was the suspected traveler associated mpox cases. They were detected during this emergency. And our interpretation based on our lab and our genomic surveillance was that we identified the clade 2B and that rare lineage. And we also identified that this patient was co-infected. And so, and we highlighted, so based on that, we highlighted the importance of differential diagnosis. So what actions were taken? I think this genomic finding, it supported rapid outbreak confirmation, and the traveler screening, which was already being done, it was enhanced, it was intensified in different airports of Pakistan. And differential diagnostic workflows, they were established in all the labs, all the public health labs of Pakistan that were testing for mpox. So they integrated differential diagnosis as well. And so overall, it led to strengthening of national mpox genomic surveillance capacity in Pakistan. So this was one of the example from mpox during 2022-23. So just recently, we are seeing a very interesting situation of mpox outbreak in Sindh, where I am right now. So we earlier this year, there was a cluster of mpox cases. They were initially identified in neonates and infant cases in a healthcare setting, and then they were then these cases, they were basically spread in the community. So genomic analysis was done by the Provincial Public Health Reference Lab of Sindh. And based on that genomic analysis, we not only identified clades, we identified different mutations. So the key findings was here that we identified the clade 1B, and this is again the clade for which the second time public health emergency of international concern was declared for mpox. So we found this clade 1B in all those cases in this ongoing outbreak. And then based on our genomic analysis, we found very, two rare, in fact, novel mutations, which are not present in any of the or any of the mpox genomes that are available on GISID or Pathoplexis. So again, this shows the significance of genomic data, but this is not enough. So, communicating this genomic data to the policymakers or to the decision makers in a timely manner is very important. And this is actually what the lab did here in Sindh. So we identified the signal based on the genomic data that this was the clade 1B variant, and it had unique mutations. So there was, based on our analysis, it was confirmed that this was basically spreading in the community, and there was no, importations or travel associated cases we identified. and what actions were taken. So based on our genomic analysis, first of all, genomic surveillance was enhanced, especially in the province. Epidemiological investigations were, intensified, and healthcare facilities preparedness was done, and this information was communicated to all the relevant stakeholders, and most importantly, the pediatric population, they have been, included in screening and in surveillance. This was something that was not done previously. So here you can see that the importance of communicating genomic data in a timely manner to the stakeholders. So the previous examples that I shared are basically how we used genomic data, or how we translated it into public health action, especially for the policymakers at the national and at the provincial level. But genomic data, especially the pathogen genomic data, it can also be used to guide clinical responses. And I'll share one example with you. So in 2024, um, in some of the tertiary care hospitals in Rawalpindi district of Pakistan, they were, reporting fatal dengue cases, and there was, a growing concern among the clinicians that there may be a new variant or a new mutation in the virus, in the dengue virus, that may be behind this fatal cases. So samples were collected from that outbreak, and they were sent to NIH. So we carried out whole genome sequencing of the samples, and in a very timely manner, we did the analysis. We translated that data, genomic data, into into an actionable form, and I'll tell you how. So we, based on our genomic data, we found that first of all, they were DEN2 and DEN1, two serotypes they were circulating, and for DEN2, it was a cosmopolitan genotype, and the subclade was 4A1, and this is again the same genotype and subclade uh, reported in this outbreak that was circulating previously in Pakistan. And the same case was for DEN1 as well. So we found that it was the genotype 3. So both DEN1 and DEN2, they shared, very high homology with the previously reported dengue viruses from Pakistan. So what was the outcome of our genomic analysis? So we shared this data with the clinicians, with our Ministry of Health, and our other stakeholders. And so based on our analysis, we reported that there was no, new genotype or unusual mutations that could, cause virulence or could increase transmissibility. So here, what was, again, the action? So I think when we shared this finding with our clinicians, so I think one of the biggest impact it had, that their focus, it basically changed from thinking about a new variant or a virulent virus or a mutation. The focus, it shifted from that to basically strengthening clinical management and strengthening the referral pathways. So I think it was a big, you can say, contribution of genomic data. So another example of how we used genomic data to inform public health action. At this time, it was in a healthcare facility, and in 2023 there was a CCHF outbreak in a tertiary care hospital of Balochistan, and some of the healthcare staff, they got infected with this virus. So the sample, again the concern was maybe the CCHF virus has mutated, or it has acquired some unique changes that is causing it to spread very rapidly among the healthcare facility. So we received samples from this healthcare facility, and we carried out whole genome sequencing, and again we did the analysis. Based on analysis, we found again the dominant Asia1 genotype that's been prevalent in Pakistan since many years. And when we compared it with the previously circulating strains, we found more than 99% homology at nucleotide level. So again, we shared these findings with that hospital, and again, we provided that there is no such change linked to such to this nosocomial outbreak. And what was the action? So again, their concentration or their focus, it again shifted towards strengthening the IPC and and protecting the healthcare workers. And later on, when the investigation was done, it was found out that this outbreak was basically due to the lapses in the IPC. So again, we can from public health action here this time again in a clinical facility. So one another example that I wanted to share with you all is of the 2023 acute hemorrhagic conjunctivitis outbreak in Pakistan. I remember at that time there was a lot of hype in media and concern in public about this outbreak because so acute hemorrhagic conjunctivitis is basically the pink eye disease, and there were around more than 400,000 cases reported in just a few weeks' time. I remember it very vividly. So we wanted, but the causative agent was unknown. So we at NIH, we wanted to, find out which is the causative agent or what is the etiology of this outbreak. So we received samples, we collected samples from some of the cases from the outbreak. And based on our metagenomic analysis, because pathogen was unknown, so we used a metagenomic approach and we find the Coxsackie A24 variant. And so and again, this variant is globally known for causing acute hemorrhagic conjunctivitis outbreaks. So, and based on our genomic analysis, we found some similarities with the VP1 region of the sequences that were previously available from Pakistan. So here, uh, the signal, as I mentioned, was the outbreak was caused by a virus which is well known to cause such outbreaks. And most importantly, here the action that was taken, it was not, maybe increasing surveillance or increasing diagnostic capacities, or it was not about, doing some hospital preparedness or that. I think one of the key questions that we addressed using metagenomic here was we identified the pathogen. So the all the panic and that fear of unknown was very appropriately addressed using our metagenomic approaches. And obviously we share this data with our stakeholders in a very timely manner. Okay, so coming to the conclusion, so there are some key principles that we all should keep in mind whenever we want to communicate genomic data to stakeholders. And one of the key principles that I mentioned previously as well, that we should be aware of the audience to whom we are communicating this pathogen genomic data. So if you are aware, you can always frame your message accordingly. Because, as I mentioned previously, not all the stakeholders or not all the audience has the same level of knowledge about pathogen genomics. So you need to know which audience you are going to, present your data. Secondly, it's very important that you not only generate the genomic data, but you also translate that genomic data into a risk. You interpret it into a risk. So, okay, this is a mutation, but what's the risk it's causing? What's the impact? What's the implication of that? This is very important, especially when we communicate such information to our policymakers. They are because they are more interested in knowing what is the risk it is causing, what impact it can have on the population. So just keep that in mind. Always use clear visuals. So when you're communicating genomic findings to policymakers or non-technical people, make sure you use pie charts, graphs, bar graphs, or such, and try avoiding, using phylogenetic trees or mutation analysis, because it will the message will not go through properly. But if you are communicating this data to scientific or technical people, so make sure you use scientific or information, but again, visual should be clear. It is highly important that genomic information, it should be communicated in a very timely manner, because there are certain actions that can be taken when we share the data. So it's important that this genomic data is communicated in a timely manner so a proper public health action can be taken. Again, it's very important how we communicate uncertainty. So as I mentioned, as pathogens evolve, so the genomic data also, it evolves. So how we communicate that data, especially to policymakers, this is very key. So we should have, those skills. And lastly, how we, as I mentioned, it's important that we should provide actionable recommendations, especially for policymakers. They are always looking for, what actions can they take. So what we are recommending to them. So make sure that we are uh, recommending to our audience or our stakeholders. So to me, I think this is a challenge that I see that a lot of the lab people, they are very good in generating the genomic data. They are very good in communicating the scientific information to scientific people, but they normally they struggle when they communicate the scientific information to non-technical people. And I think this is one skill that we need to build uh, among our genomic community, how to communicate this the same genomic data in a different form to different audiences. So I'll conclude with some key to take home messages. And as I mentioned, genomic surveillance, it is only in fact impactful when translated into action. So just the sequence data is not enough. We have to translate it into an action. Different stakeholders require different communication strategies. Real-time reporting enables timely public health response. So it's always important to communicate the data in a timely manner, ideally in real time. But that also has a lot of challenges because we know that sequencing, it takes time. And then genomics, it can guide both policy at the national, at the larger scale, as I shared some examples with you. But genomics can also guide clinical decision making at the individual level, and I also shared a couple of examples of those as well. And lastly, um, effective communication, it is as important as the sequencing capacity itself. So I think I'm just over time, so I'm happy to take any questions if there are any. Thank you.
Thank you, Dr. Nassar, for that wonderful and amazing presentation. For those that are willing or would like to ask any questions, please post them in the Q&A box, and I will read them out and have Dr. Nassar answer them. If there are no particular questions in the meantime, I would like to ask one or two of my own, if that's all right. Firstly, again, thank you very much for a spectacular presentation. And I do agree that the different strategies for communicating information is very critical. But I just wanted to find out what are the sort of data privacy and sort of ethical considerations that are needed when, or need to be considered, sorry, when you are communicating to various stakeholders, as I'm sure that each of them require different sets of information, different types of information. And sort of, as you mentioned, especially in a very rapid turnaround time, how do you ensure or mitigate that there isn't any sort of potential risk or harm done towards the communities during the surveillance?
Yeah, thank you. So I think one of the things that we can do is to, while ensuring ethical principles, is to make sure that patient confidentiality is not breached. We are not sharing data regarding regarding the patient, and this is something that we always make sure that it's not shared. We are sharing aggregate data. We are not sharing individual specific data, and we try to make sure that we only include geographic location whenever it is necessary, and we don't, create some stigma, especially, for mpox and for like pathogens like HIV. So we are also seeing an HIV outbreak in Sindh, in Pakistan, where I am right now. So we need to, whenever we are communicating genomic data, we need to make sure that we are not, breaching all these important areas. Yeah.
All right. We then have a question from Andrea who asks, are genomic data integrated automatically and directly into electronic surveillance systems, or what are the challenges for integrating this information for action?
Yeah, that's a great question. Actually, I think it's a major, challenge that we are facing in Pakistan at the moment. Short answer will be, no. At the moment, we are not, properly integrating genomic data with our epidemiological data or with our clinical data. There is a challenge, and it's a challenge. We just recently made a dashboard where we upload our genomics data, and to some extent we also upload some of the, available clinical data. But how can we integrate the genomic data with clinical, with epidemiological, and sometimes even environmental data? I think this is one question we all need to, answer as a genomic experts or a genomic community. And the major challenges that I foresee is that, um, first of all, I would say, the epidemiological side or the surveillance side, they normally do not share, the epi part of the data with the lab side. This is a very, big challenge. Whenever we receive, samples, there is very limited information provided to us on the request forms. So we always keep going back to those, the people who have collected samples. So this is one challenge that I can say we are facing. And then there are normally not available platforms that can, integrate such complex genomic data with the simple, you can say, clinical or epidemiological data. So these are some of the challenges that we face in Pakistan.
All right, thank you very much for that answer. As a follow-up to that, Emma has asked, for the data communication that you undertake, when do you choose to communicate orally versus written reports, and what sort of strategies are in place to rapidly reproduce or produce, these reports?
Yeah, again, a very, I think, good question, a very relevant question. So during the, different public health emergencies, especially which were termed as public health emergencies of international concern, like the ongoing mpox or the COVID. So we had to, communicate genomic data both orally and as well as, in form of reports with our stakeholders. So as I mentioned, so I had to brief them orally during those NCOC sessions. So there was, it was a combination of sharing data both in physically and then sharing wide reports. Sometimes we share data, especially, the examples that I gave about clinical, where clinical decision making was done. Most of the times we share data in form of reports. So we make a report, and then we share the report with the end user or with the relevant stakeholder. We did, we took a very unique step during the pandemic, and which we still follow, that we made genomic situation reports for SARS-CoV-2, for mpox, and we included all the information that could be, understandable by different stakeholders, and we share this genomic situation report with different stakeholders, either directly, or we also use to upload this genomic situation reports on our NIH website. So again, it depends it depends on the situation, it depends on the stakeholders, and it depends on the urgency, how we communicate data to different stakeholders.
Excellent, thank you very much. And then there is another question in the chat from Justice. Have you ever faced misinformation during an outbreak response, and how did you manage it?
Misinformation, like
So I would assume that if any sort of false information or incorrect information is currently being spread during an outbreak response, how is it managed?
I think one example would be, the acute hemorrhagic conjunctivitis outbreak. So there was a lot of, misinformation surrounding that outbreak, that it was being spread due to some, I don't know, something that is, extremely dangerous, something that is highly lethal, or maybe, but uh, but our, genomic analysis and genomic investigation, it basically provided evidence that that was not the case, and it was a common pathogen that has been linked to these outbreaks globally.
Excellent. Thank you very much. I have sort of one more question on my end as a follow-up. I know you highlighted at the start of your presentation that the sequence alone isn't the most critical thing. It's the process that it undergoes from the sample to the actual public health action. How do you, if it is done, measure the actual impact of the actual final, whether it is a new policy, it is a particular response? How, if it is done, how do you go about doing that? Or do you have any recommendations about how you would actually go about measuring the downstream impact within the community?
Yeah, so normally we look at, the cases. Uh, so just an example for the ongoing mpox outbreak in pediatric population here in Sindh. I was here one month ago as well. So we recommended increasing and intensifying genomic surveillance to see which clade is circulating, and then based on that, our findings or our recommendation, genomic sequencing was carried out in the provincial lab here. And because of that, we managed to find out that it was due to the clade 1b variant, and it has unique mutation. So based on this clade 1b findings, again, this information was shared with different stakeholders, with especially people who take actions. And based on this, they, increased surveillance, especially in not only in that pediatric population of that of that healthcare setting, but they started, they enhanced this surveillance in the wider community. So this was one example where we used, and the best, you can say, the outcome was that cases have gone down considerably. So we reported several cases last month, and it's been more than a month. So we have just reported a few cases. So we look at the cases, or we look at the different measures to see whether, our genomic findings, they are being, effective or not.
All right, thank you very much. We've got one more question in the chat before we close up. How do you ensure minimal lag time between real-time reporting and timely communication?
Sorry, can you repeat? How do we?
Sorry, how do you ensure minimal time lag between the real-time reporting as well as the timely communication to the various stakeholders?
Yeah, again, a very good question. I think this is a very big, challenge for LMICs, and for, countries that have limited genomic capacities. Normally, we look for, we wait for a batch of samples to process on, sequencing. But in some cases, especially where there is an urgency, we don't wait for, a batch to be, ready. So we directly process a sample that we receive in our lab, and we obviously, it increases the coverage number of many times, but it has, again, it has direct implications on the public health action. So one of the things that we do is we directly process the sample for sequencing, and most of the times we repeat it in duplicates or triplicates, so that we don't have to repeat it again if there is a issue with the sequencing quality. So we can maybe retrieve the sample from the retrieve the sequence from the second sample as well. So we do these type of small things.
All right, thank you very much. As we are on the hour, I would like to once again thank everyone for their time and for Dr. Masab for his presentation. Thank you very much, everyone, and I will now be closing the session.